Good afternoon, friends. It's my privilege again to welcome you all for the last part of our series on critical care, the perioperative critical care. As we discussed earlier, this series is we decided to have this critical care for the discussion. Yeah, we can upgrade ourselves. We had almost about 16 topics and 12 topics already we have discussed in part one, part three, and today being the last part of the series. So to moderate this, we have a special guest, Dr. Subbareddy. Thank you, Dr. Subbareddy, for being with us. Can you focus the camera on him? Dr. Subbareddy needs no introduction. He is the Chief of Critical Care at Apollo Hospital, Hyderabad, Jubilee Hills. He did his master's in anesthesia. Subsequently, he did his PTC neuroanesthesia and IDCCM and FCCM and EDIC. So he's been practicing critical care and especially critical neurocritical care for the past almost 10 years at Apollo Hospitals, Hyderabad, and he's recently elected as a national EC member of ICCM nationally. He's a past chairman of ICCM Hyderabad City Branch, and he also is the medical director of Epicos Rehab Center Hyderabad. And importantly, he is a lead for clinical specialty training in intensive care, and he also is the chairman of Apollo Macquarie program, basically IAPE and chapter of Hyderabad. So, welcome Dr. Subbardi for this webinar, and it's our privilege to have you here. Before we go on to the topics, which are again interesting topics have been lined up, four topics have been lined up, which will be introduced to you by Dr. Kiran and my colleague Dr. Dayakar. But before that, I would like to have some comments from our chief moderator, Dr. Subbardi.
Good afternoon, viewers. Thanks to Sunil Pandya sir and AIG Hospitals for inviting me here as moderator. All the anesthesiologists should have very sound knowledge in critical care to manage their patients, any complication perioperatively. And when I looked at the topics, they're very good topics. Right from like the cardiac arrest, intraoperative cardiac arrest, or the new topic that is health and well-being of ICU physician, and the other topic about the stroke, perioperative stroke. And thanks to AIG Hospitals and Sunil Pandya sir team for doing these perioperative anesthesia clinics and involving critical care as one of the topic. Thank you, sir.
Thanks, Dr. Subbardi, for the kind introduction. May I now request my co-moderator, Dr. Dayakar, also to come onto the podium, please. So I must introduce my colleague, Dr. Kiran, who is a senior consultant and in charge of surgical ICU at AIG Hospital. He has been associated with us more than a decade now. He did from his master's in anesthesia from Osmania Medical College, and he worked as a senior consultant in cardiac anesthesia for almost 5 years at Care Hospital, Mushirabad. And subsequently, he did his fellowship in critical care at DCCM from the course run by ICCM. And he also completed his EDIC, and currently he is in charge of surgical ICU. He's passionate about surgical intensive care. Very few critical care specialists, they focus themselves in the perioperative critical care. Thank you, Dr. Kiran. I also introduce my colleague, Dr. Dayakar. He is again with us for almost more since 2013. He also is a alumni of Osmania Medical College, a senior consultant in anesthesia and perioperative medicine. Thank you, Dr. Dayakar, for being with us. So I hand over the proceedings to Dr. Kiran, and he'll introduce the speaker and topics for the day. Thank you, Dr.
Good afternoon to one and all, and especially those who are watching this live webinar session. Welcome to the Perioperative Critical Care web series part 4. Today we have 4 interesting topics. Uh, First one is the management of intraoperative cardiac arrest. The second one is not all shock states are created equal. The third topic is perioperative management of the acute stroke. And last topic is on health and well-being of an ICU physician. Let's begin with the management of intraoperative cardiac arrest by Dr. Lakshmi Bhargavi. She did her DA and DNB, and she's working as a consultant at AIG Hospital. Over to Dr. Bhargavi.
Thank you, sir. Good afternoon, everyone. My topic is management of intraoperative cardiac arrest. So first we need to know how is it different from other types of cardiac arrest. Generally, it is a witnessed cardiac arrest and it is always anticipated, which helps us in a focused and early intervention, which finally leads to a better outcome. And we are fortunate that it's a very rare incident. The incidents in India being only 3 patients for every 10,000 anesthetics. Who are the patients at risk? Generally, any emergency surgery we undertake or any cardiothoracic surgery or vascular surgery are at risk of intraoperative cardiac arrest. Patients with comorbidities like congestive heart failure, peripheral vascular disease, pulmonary artery hypertension, end-stage renal disease, shock, polytrauma, or with any electrolyte abnormalities, these patients are at high risk for intraoperative cardiac arrest. What do we need to monitor? First is our regular AHA standard monitors, which include ECG, non-invasive blood pressure, pulse oximeter, and ETCO2. Along with that, in anticipated cases, we need to apply special monitors like 5-lead ECG with ST segment analysis, a pre-induction arterial line, and a pre-induction transcutaneous defibrillator adhesive patches has to be applied. Placement of central venous catheter can be decided on case-to-case basis, and intraoperative transesophageal echo and POCUS plays a major role whenever available. Most important point here is we have to keep all the alarms on so that we don't miss out on the slightest clue. How do we recognize an intraoperative cardiac arrest? Yes, it is very challenging because the patient is under drapes. We may not be able to access the pulse. We may not be able to see the respiratory movement. So we need to rely on the monitor mainly. So the ECG will may show any rhythm disturbances like ventricular tachycardia or ventricular fibrillation or any pulseless electrical activity or severe bradycardia or asystole. We need to confirm that by checking the large artery pulse like carotid, or in case of head and neck surgeries, femoral pulse. We need to check it for less than 10 seconds. Along with ECG, arterial BP and pulse oximeter, loss of waveform is there in the arterial BP and pulse oximeter. Here, the best guide for us is ETCO2 because there will be a gradual decrease in ETCO2 and finally ETCO2 will be lost. When such scenario is present and we recognize a cardiac arrest, we need to start CPR immediately according to the ACLS guidelines. And any delay of more than 2 minutes in an intraoperative setting witnessed cardiac arrest, any delay of more than 2 minutes will cause a poor outcome. So the idea here is we need to trust the monitor, not think that there is lead disconnection or any technical issue. First, look at the patient and then at the other things. When a cardiac arrest is suspected, immediately we have to follow the standard ACLS protocol, which all of us are aware of. So in intraoperative setting, how do we know it is an effective CPR? As we have emphasized, ETCO2 is the best guide. So throughout the chest compressions, if the ETCO2 is more than 20 millimeters of mercury, it gives a better outcome. If the diastolic relaxation pressure is around 30 to 40 millimeters of mercury, it is better. That is, during chest compressions, during the chest recoil, if the arterial BP tracing is showing somewhere around 30 to 40 millimeters of mercury, it gives us a better result. And an ETCO2 of less than 10 millimeters of mercury for continuous 20 minutes shows a poor outcome. When do we say return of spontaneous circulation is achieved? when EtCO2 is persistently maintaining above 35 to 40 millimeters of mercury, when arterial waveform is present, when a large arterial pulse is palpable, with a recordable non-invasive blood pressure reading. Okay, and uh, this open chest cardiac massage was of historical importance earlier, but now studies have been conducted, especially in the perioperative setting, where open chest cardiac massage has showed good results and a faster ROSC has been achieved. Here, left anterolateral thoracotomy can be done, or if it is off, if abdominal surgery is going on, subdiaphragmatic or transdiaphragmatic approach can be done to directly assess the cardia, and gentle massage with single hand can be performed. This is called resuscitative thoracotomy. There are no specific guidelines for this, but if ROSC is not achieved within first 10 to 15 minutes, and if veno-arterial ECMO is not available, open chest cardiac massage can be done. A new concept which is coming up for refractory ventricular fibrillation, that is if ventricular fibrillation is prolonged, a new concept has come, that is a vector change defibrillation is used. Here we can switch the connection of the defibrillator patches from anterolateral, which is the conventional method, to anteroposterior position. And the other method, which is the new method in use, is a double sequential external defibrillator, where two defibrillators are attached, one in the conventional anterolateral position and the second in anteroposterior position. So here the provider gives shocks almost simultaneously. That is, the provider gives the shock in the anterolateral patches first, and with a gap of 1 second, he gives the next subsequent shock immediately. So this has resulted in faster ROSC and better cardiac output states. Coming to the non-supine positions in intraoperative setting, the main goal is to reposition immediately. So if the patient is in prone position, yes, it takes time to convert into supine position. So till then, thoracic spine compressions can be done, but it is less effective. In lateral position, to achieve adequate chest recoil, we need to provide a back support. And in Trendelenburg position, beach chair position, or in any other position, we need to reposition immediately. For robotic surgeries, we need to inculcate a system to undock immediately so that we can act immediately on the patient. And in special situations like in pregnancy, undergoing any non-obstetric surgeries, manual left uterine displacement and resuscitative uterine interventions have to be done. This is the protocol for ACLS in pregnancy. This is devised by Dr. Sunil Pandya himself. Here, within the first 5 minutes, we need to first start chest compressions, and continuous constant manual left uterine displacement has to be provided. And within 5 minutes of identification of the cardiac arrest, the resuscitative uterine interventions, that is delivery, has to happen. The term perimortem cesarean section is no longer used. Now we use the term resuscitative uterine interventions. Yes, cardiac arrest can occur in anaphylactic cases also, which will be discussed later by my colleague Dr. Sneha. Obstructive physiology in surgeries like laparoscopic surgery or hysteroscopic surgery, when there is pneumoperitoneum, or if the patient is already having any emphysematous bulle, spontaneous pneumothorax, hemothorax, or any trauma patient, a combination of pneumohemothorax can occur, which will suddenly lead to cardiorespiratory collapse and pulseless electrical activity. It can be iatrogenic also, which includes our central venous catheterization. In surgeries like neuroendocrine tumors, while handling, there can be extensive histamine release or serotonin release, which can cause bronchospastic crisis or cardiovascular collapse, which will be immediately seen on the monitor. So in anesthetized conditions, we have to again rely on the monitor totally. As we said, it can occur in laparoscopic surgeries also. And immediate diagnosis is availability of transthoracic echo, transesophageal echo, and focus intraoperatively. Here, emphasis is on empiric intervention. That is, we need not wait for the diagnosis. If we are suspecting any pneumothorax or hemothorax, which is impairing the respiration, immediate needle decompression or immediate intercostal drainage insertion has to be done. Local anesthetic systemic toxicity. This is also a very rare situation, but a very devastating situation. The key here is to identify the situation. That is, many times we may miss it because it presents initially with CNS excitatory symptoms like restlessness and anxiety, which may be missed as a general functional behavior. So the symptoms vary between mainly CNS and CVS symptoms. CNS, initially the symptoms will be excitatory symptoms leading to seizures, and finally depressive symptoms like coma and respiratory arrest. And cardiovascular symptoms come in 3 phases. That is, initially there can be tachycardia, hypertension, which can also be mistook for apprehension and pain, followed by intermediate phase where there is myocardial depression with hypotension, bradycardia, and finally cardiac arrest. And these for local anesthetic systemic toxicity, they can go into refractory cardiac arrest very easily. So the symptoms depends mainly on the CC-CNS ratio, that is the dose required for the local anesthetic dose required to cause cardiovascular collapse versus the dose required to cause seizures. So for bupivacaine, it is 2, that is very less, and for lignocaine, it's 7.1. That means the dose required to cause cardiovascular or neurological problem for bupivacaine, there is a very narrow margin. But for lignocaine, we have a wide margin, that is a lower dose is required to cause CNS toxicity for lignocaine, but for CVS toxicity, you need a higher dose for lignocaine. Whenever we are suspecting local anesthetic systemic toxicity, immediately stop administering the drug, secure the airway, and administer antiepileptics like midazolam, short and fast acting, and administer lipid emulsion. The dose of lipid emulsion, we all know it is 20% lipid emulsion. First, initially we give 1.5 ml per kg over 2 to 3 minutes, followed by 0.25 ml per kg per minute. And if the symptoms don't subside, we double the dosage, we increase it to 0.5 ml per kg per minute. Here, the dose of adrenaline and other inotropic agents is reduced. That is, the dose of adrenaline in last is 1 microgram per kg. It is decreased. Why do we decrease? Because the full regular dose of adrenaline can worsen the arrhythmias, as the local anesthetics are direct cardiotoxic agents. If we administer full dose of adrenaline, it can precipitate ventricular fibrillations. Full dose of adrenaline can also impair pulmonary gas exchange. It may increase the afterload and hence increase the lactates, and it will also interfere with the lipid resuscitation. Also, we need to avoid inotropic agents like vasopressin, beta blockers, and calcium channel blockers for same reasons. The drug of choice for ventricular fibrillation or ventricular tachycardia is amiodarone straight away. In last, prolonged cardiac arrest is common. So prolonged CPR has to be continued till ROS is achieved. There are cases where almost 1.5 to 2 hours of CPR has been done and patient has been revived. The last resort here is extracorporeal cardiopulmonary resuscitation. Coming to malignant hyperthermia, this is another rare condition, but again a devastating condition. Generally, these patients have a positive family history, a vague positive family history. Malignant hyperthermia mainly occurs because of mutation in ryanodine receptors. That is, in the skeletal muscle, they release excessive calcium, and the skeletal muscle goes into a sustained state of contraction. Triggers here are succinylcholine and volatile agents. Because of the sustained state of skeletal muscle contraction, they go into a hypermetabolic state, and cardiac arrest eventually occurs if untreated. It eventually occurs because of hyperkalemia, because of the release of potassium from the skeletal muscles. The key here is to stop the offending agent, that is the volatile agent or scoline, whichever we were giving, and the treatment is IV dantrolene. Yes, it is very less available and very difficult to administer also. So it's better to prevent malignant hyperthermia than to wait for it to come and treat. Next is hyperkalemia. Generally, patients who are at risk for hyperkalemia, patients with acute kidney injury or chronic kidney injury, immobile patients who are being administered succinylcholine, patients with a family history of malignant hyperthermia, trauma patients, burn patients, and patients who have undergone massive blood transfusions. We have to intervene only if there are signs of hyperkalemia present or if the value is more than 6 millimoles per liter. So generally above 6 millimoles per liter, we see tall T waves on the ECG. From 6 to 7, we see wide QRS complex absent of P waves, and beyond 7.5 to 8, we see sine wave pattern on ECG. This sine wave pattern is called a pre-cardiac arrest rhythm, and after that, it generally precipitates into VT or VF. So the initial treatment, whenever we are suspecting, initial treatment is membrane stabilization to prevent the cardiac arrest. We give IV calcium gluconate 10 ml over 10 minutes, followed by which is a definitive treatment, that is we have to shift the potassium intracellularly, for which we use dextrose insulin combinations and beta blocker, and we give beta agonist nebulizations. And definitive treatment is to eliminate excess potassium from the body through resins or mainly hemodialysis. The hyperkalemia can precipitate cardiac arrest, and it can also be a prolonged cardiac arrest. Prolonged CPR has shown better results. Coming to different types of embolisms: venous embolism, arterial thromboembolism, gas embolism, fat embolism, amniotic fluid can be encountered. How do we immediately diagnose an embolic state? Under anesthesia, there will be a rapid hypotension, rapid desaturation, sudden decrease in EtCO2, sudden arrhythmia, sudden pulseless electrical activity, or directly a cardiac arrest. This mainly occurs because of the ventilation perfusion mismatch in the lungs, leading to right ventricular afterload increase and right ventricular dysfunction. What helps us here is on-table TTE, where on-table 2D echo will show us, this is the four-chamber view, where is the left atrium, left ventricle, right atrium, right ventricle. We can see a significant dilatation of the right atrium and right ventricle, which is diagnostic of pulmonary thromboembolism. So when we have diagnosed pulmonary thromboembolism, immediately first we need to treat the scenario intraoperatively. If we are suspecting air embolism, we need to cessate the air entrapment. If we have to make the patient supine, flush the surgical field with saline so that again air doesn't get entrapped. Keep the patient in Durant's position, that is head low and right up, so that the air gets collected into the right atrium and we can aspirate it through the central venous catheter. Supportive treatment and anticoagulation have to be administered to the patient. Again, anticoagulation, we need to see the risk benefit, and because we do not want any surgical bleed to happen. Inotrope of choice here is vasopressin because it does not cause pulmonary vasoconstriction. And here ECMO is again the last resort. In situations like cardiac tamponade, which generally occur in procedures in our cath lab, immediate pericardiocentesis should be done and volume expansion should be done. Here chest compression takes the second seat and volume expansion takes the first seat, because we need to fill the heart first, which will again improve the cardiac output. And in patients with, sometimes we may encounter patients coming for a non-cardiac surgery who have undergone a cardiac transplant before. So we have to keep in mind that they have a denervated heart. So they do not have any reflex tachycardia or bradycardia. They don't respond to our drugs which cause reflex tachycardia or bradycardia. So the only drugs useful in these patients will be adrenaline, isoproterenol, noradrenaline, and glucagon. Coming to hypovolemic cardiac arrest, either hypovolemia or hemorrhage can happen during surgery because of accidental vessel cut. So we need to prioritize on massive transfusion and volume replacement again over chest compressions. We need to do simultaneously, but massive transfusion and volume replacement has to be done immediately. Otherwise, the chest compressions will not reveal a good result. Here again, POCUS is strongly recommended It helps us to detect the cause of the hypovolemic cardiac arrest. It helps us to differentiate between pseudo and true pulseless electrical activity. That is, in pseudo pulseless electrical activity, we don't feel a pulse because of low volume, but still the electrical activity is there on the monitor. So we need to do the volume resuscitation first. And POCUS helps us in targeting the resuscitative efforts, and it helps us in ruling out the other reversible causes. And if hypovolemia persists, manual compression over the aorta or aortic cross clamping can be helpful, or resuscitative endovascular balloon occlusion of the aorta can be helpful, but these are temporary measures till the actual hemorrhage is controlled. Coming to the post cardiac arrest management, this is the standard ROC protocol of the AHA guidelines. What we do here is, first, simultaneously while doing CPR, we have to see for the 5 H's and 5 T's. That is the hypoxia, hypothermia, hypo or hyperkalemia, acidosis, and 5 T's, that is the toxins, cardiac tamponade, thrombosis, pulmonary thromboembolism, or coronary thromboembolism, or tension pneumothorax. And the goals after achieving ROSC, the goals are early airway protection with an endotracheal tube, to provide adequate oxygenation and ventilation, to hemodynamic monitoring is a must, to prevent further neurological injury, strategies to prevent re-arrest, and organ protective strategies. We have to keep all this in mind. So for lung protective ventilation, this is after ROSC. For lung protective ventilation, we need to titrate PEEP, because again increased PEEP may cause hemodynamic disturbances. So we need to titrate PEEP to target a PaO2 of more than 60 millimeters of mercury. We should target a saturation of more than 94%. Target a PaCO2 of 35 to 45, not more, not less, because increased PaCO2 will again cause cerebral vasodilation, cerebral edema, and further cerebral injury. And decreased PaCO2 can again cause cerebral vasoconstriction and further deteriorate the neurological condition. We need to maintain a mean arterial pressure of more than 65 millimeters of mercury with IV fluids and inotropes for adequate organ perfusion. We need to correct the electrolytes timely. Maintain euglycemia of 140 to 180 milligram per deciliter. Seizure prophylaxis have to be given round the clock, and early trophic feeds by an orogastric tube has to be started to prevent gut ischemia. And so how do you prognosticate for a better outcome? We have to follow the organ protective strategies as already mentioned. That is, for CNS protection, we need to target a targeted temperature management protocol is used in our hospital. That is, we maintain a temperature of 32 to 36 degrees centigrade for 24 hours, and maintain EtCO2 from 35 to 40 millimeters of mercury. For cardiac protection, we need to maintain the MAP more than 65 with the use of inotropes and IV fluids. For lung protective ventilation is already discussed. To maintain, we have to maintain perfusion of the kidneys so that the patient doesn't go into AKI. To prevent GI problems, adrenaline infusion can hamper the splanchnic circulation, so it's better to titrate the dose and wean off the dose of adrenaline as soon as possible, and to start the enteral feeds as soon as possible. Then yes, there can be adverse effects of prolonged cooling. That is, it can cause myocardial depression, bradycardia, hypotension. It can cause increased tendency to bleed. So we need to reevaluate the patient every 24 hours. After the first 24 hours, to see if we can rewarm the patient and bring him to the normal conditions. These are few cases which we have encountered in our hospital. We had a ASA1 patient of 19-year-old female who came under daycare surgery for endoscopic sinus surgery. Intraoperatively, the procedure went uneventful. Patient was extubated, shifted to recovery, and when the patient was shifted to recovery and monitors were attached, she was found unresponsive with loss of waveforms in the monitor, and there was loss of peripheral and central pulse. So immediately CPR was started. IV adrenaline was given, patient was intubated, and ROSC was achieved within 2 minutes. Patient was started on inotropic support, followed by which then over the next 24 hours, she was weaned off all the inotropes, and the ventilator. And the next day morning we extubated her. In those 24 hours, all other evaluations, cardiac evaluations, everything was normal. Most probable cause what we were suspecting is aspiration, which finally led to hypoxia and unresponsiveness. So we need to be vigilant here. The monitor waveform getting lost, we should not um, neglect such aspects, is what is the take home. There is another case where we had a 70-year-old female patient with a coronary artery disease who was status post PTCA with a moderate LV dysfunction, hypertension, diabetes, AKI, and old CVA. She underwent hemiarthroplasty under combined spinal epidural. Because of the comorbidities, all advanced monitors were attached, which included the 5-lead ECG, arterial BP, defibrillator patches were attached, and 2 wide-bore cannula were secured. And immediately after cementing, we observed sudden unresponsiveness. There was sudden hypotension, bradycardia, which led into asystole. So we immediately asked the surgeon to stop the procedure, and immediate CPR was given, and 1 dose of adrenaline was given, and patient was intubated, along with which IV fluids boluses were given, and return of spontaneous circulation achieved within 1 minute. Patient gained consciousness also. So they finished the procedure within 20 minutes. Shifted the patient to the ICU. Post-operatively, we found out that the LV dysfunction had come down. So she got extubated the next day. Slowly the inotropes were weaned off, and eventually she got discharged after 1 week. So here the most common suspicion is bone cement implantation syndrome, which we have encountered, and or fat embolism. These are very common scenarios. So in our hospital, what do we do? Whenever such a scenario occurs, first we need to take care of our colleague, because we'll be under guilt that it has happened because of us. The first victim being the patient, our colleague being the second victim. So documentations and sequence of notes of all the team members have to be on similar notes, and everything should be written down clearly. Communication with the family has to be done. A single spokesperson every time, the same person, and has to uh, communicate with the family together with all the multidisciplinary team. How do we achieve a better prognostication, better quality of CPR? As we saw early ROSC, if is achieved, we can get a good prognosis. In the post ROSC, continuous EEG monitoring has to be done so that we can detect any seizure activity or any neurological deterioration. Post resuscitation protocols have to be followed. If there is hemodynamic stability and neurological outcome is good, slow rewarming has to be done. And when do we reassess? CT brain has to be done after 24 hours. And if cooling is continued, after third day, we do a MRI brain to see the neurological outcome of the patient. Thank you.
Thank you, Dr. Lakshmi, for that excellent talk. You covered almost all the topics, but this is a very important and when you have this, when there is intraoperative cardiac arrest, entire team will be demobilized, and what are the consequences of this? So that's why most of the time, like we take all the precautions to prevent this. And nowadays we get a lot of patients from other part of the from different countries. We get patients because of the medical tourism. We get African patients, then they travel long distance, and then they come here. In our institute, we had long back, we had one patient who traveled, who took transatlantic flight and came for simple disc surgery. After the surgery, when they were positioning the patient had a cardiac arrest. So then we did immediately 2D echo, and then identified it is pulmonary embolism. We took the patient for thrombectomy. So, and see, whenever, if you take care of the patient, if you have the right protocols, and like suppose if you have a pulmonary embolism, if you activate PERT team, that is pulmonary embolism response team, you can't thrombolize this immediately after the surgery. And then you can take the patient to cath lab, and then you can do thrombectomy. And if you identify these patients before, and then do Doppler, and then postpone the surgery, or giving anticoagulation for the surgery, all these things help. Um, and one more thing, in the post cardiac arrest care, now the evidence for hypothermia is initially it is deep hypothermia, and it is moderate hypothermia. Then it came to, after TTM1 and TTM2 trials, it came to mild hypothermia, that is 35 to 36 degrees. But now, after the latest study, the TTM2 trial, there is no much benefit with hypothermia. It is only normothermia. After cardiac arrest, if you maintain normothermia, that is enough. That is basically fever control, what they practice. And then neuroprognostication. As you rightly said, it is witnessed, and then it happens in front of anesthesiologist, the team. So we immediately resuscitate, and then think the neurological recovery is good. In most of the patients, the neurological recovery is good, but sometimes if you have a old patient and then with a lot of comorbidities, then they may not wake up post-operatively after the cardiac arrest. Then the neuroprognostication will come into a play, will come into a picture. And how do you prognosticate? We don't prognosticate based on one or two imaging, like not based on CT or not based on MRI. First, clinically, we see what is the response, and if it is M2 response, or if the patient is getting continuous myoclonic jerks, or if you have a simple bedside, if you do somatosensory evoked potentials and the absence of N20 potentials. And then in some centers, we do neuron specific cannulas. By doing all, and then of course, definitely, as you said, CT and MRI after 72 hours, then based on that, we prognosticate. You have to tell them what is the prognosis. Otherwise, indefinitely, I know one patient who had cardiac arrest intraoperatively during, they went for elective hysterectomy, and then the patient went on tracheostomy and stayed for a few years. So it is very traumatizing for everyone. The prognostication part is very, very important. Later, medical legal aspects. What are the medical legal aspects when it happens? The young patient coming for elective surgery had a cardiac arrest. We have not taken high risk consent. Sometimes, if it is high risk consent, definitely based on the comorbidities, based on the complexity of the surgery, we take high risk consent. Then we are not in we are not in major problem. But young patient, how do you take care? But if you have standard monitoring intraoperatively, then if you have a qualified anesthesiologist throughout the procedure, many times anesthesiologist go out and then a technician will be monitoring. And if they document, if they find these things, then medical legally it will be a problem. But if you have standard intraoperative monitoring, then if you have provided standard care to the patient, then medical legally also we will not have any problem. And then after the cardiac arrest, if you identify, if you take proper steps to save the patient, you will not have any medical legally. Thank you.
I have a question. Is there any role of prophylactic, any role of anti-protein prophylaxis procedures in post-cardiac arrest?
Definitely no role for prophylactic anti-seizure anti-epileptics, because we know even in head injury, the anti-epileptics prophylactically we don't give unless these people are at very high risk for seizures, because during recovery it affects the cognitive function when you give anti-epileptics. And if when you start anti-epileptics, how many days you have to continue, we don't know. The young patient had cardiac arrest and then immediately recovered, and then you put the patient on antiepileptics, and then antiepileptics will continue for 3 months, 6 months, and then they don't withdraw. And then when the patient is on antiepileptics, there are a lot of restrictions, can't drive and all those restrictions, but not required. Sometimes the patient will be getting myoclonic jerk. That is one of the most important prognostic factor in the post cardiac arrest scenario. If the patient is having myoclonic jerks, then the prognosis is poor. It is very difficult to control this status myoclonus. We give 1, 2 antiepileptics, 3 antiepileptics. Sometimes you may not control status myoclonus, and then we have to give. Sometimes we'll end up in giving midazolam infusions and all. But unless there is documented seizure activity in the EEG, or you see the patient is seizing actively in front of you, then you give anti-seizure medication. Otherwise, there's no role for prophylactic anti-epileptic medications, but definitely there's a role for neuroprotective agents, like we give piracetam, we give citicoline, all these antioxidant medication, for the neurological recovery. We give high dose paracetamol for these patients.
Thank you, sir, for your inputs. And let's move to the next topic. Not all shock states are created equal. A review of the diagnosis and management of the septic, hypovolemic, cardiogenic, obstructive, and distributic shock by Dr. Sneha. She did her DA and MD anesthesia from CMC Vellore. Over to Dr. Sneha.
Good evening, everyone. Today, my topic is on not all shock states are created equal. So, before going into different types of shock, we will first talk about what is shock. Shock in general, we should know it is not equal to hypotension alone. It is hypotension. It is hypotension along with the hypoperfusion, leading to decreased oxygen supply at the cellular level, that in turn is causing organ system failure. So various types of shock, there's a decreased cardiac output. So the cardiac output is the measurement of the amount of blood pumped by each ventricle in 1 minute. It is heart rate into stroke volume. The stroke volume is end diastolic volume minus end systolic volume. So what are the factors that are affecting the cardiac output? So the cardiac output is heart rate into stroke volume. The heart rate is in turn dependent on autonomic innervations and the hormones in our body. The stroke volume, when you see, it is difference of the end diastolic volume and end systolic volume. The end diastolic volume is in turn dependent on the preload of the heart, which is in turn dependent on venous return and filling time. So if the patient is having tachycardia, there will be a decreased filling time and the period will also come down. The end systolic volume is dependent on contractility and the afterload. The contractility is in turn dependent on our autonomic nervous system and hormones. The afterload depends on our vasodilation or vasoconstriction. There are 4 different types of shock. The first is a hypovolemic shock. In hypovolemic shock, there is a decreased volume in our body affecting the venous return, that is in turn decreasing the cardiac output. In an distributor shock, it is causing severe vasodilation, so it is decreasing the afterload. In cardiogenic shock, there is an effect of the cardiac pump, so the contractility will come down and that is decreasing the stroke volume. In an obstructive shock, there is an obstruction to the outflow of the cardiac output, which in turn decreases the cardiac output. So when the patient presents with a shock, on clinical examination, we need to see whether the patient is having warm extremities or cold extremities. The patient is having warm extremities, you think about distributive shock. If the patient is having cold extremities, we need to examine the JVP. If the patient is having high GVP, it can be either a cardiogenic shock or it can be an obstructive shock. To rule this out, we have to do an emergency 2D echocardiogram. If the patient is having low GVP, then it can consider to be hypovolemic shock. So the patient presented with the shock, there are signs of tissue hypoperfusion like in brain, altered mental status, skin, cold mottle skin, kidney oliguria. And in the heart, patient is having tachycardia and elevated blood lactate levels. We will estimate the cardiac output and mixed venous oxygenation. If the cardiac output is normal, then we should consider distributive shock. If the cardiac output is low and CVP is also low, we should think of hypovolemic shock. If the cardiac output is low and CVP is high, we should think about cardiogenic shock or obstructive shock. So now we'll talk about the hemodynamic variables in the different types of shock status. First, we are talking about hypovolemic shock. In hypovolemic shock, there is decreased CVP. Because of the decreased CVP, there is a compensatory sympathetic activation increasing your systemic vascular resistance. That it also increases the heart rate. Because of the tachycardia, there will be an initial increase in cardiac output. Later, and when it went to decompensation, the cardiac output will also come down. The pulmonary capillary wedge pressure will also be low. In cardiogenic shock, there is a cardiac pump failure, so there is a decreased cardiac output. As a compensation, there is a sympathetic system activation and increased systemic vascular resistance. There is backward pressure into the pulmonary circulation and into the systemic circulation. The pulmonary circulation is seen by increased pulmonary capillary wedge pressure. and systemic circulation, we can see a rise CVP. In obstructive shock, there is an obstruction to the outflow of the cardiac output, so there's a decreased cardiac output. Because of the back pressures, there's an increased pulmonary capillary wedge pressure and increased JVP. In distributive shock, there is severe peripheral vasodilation, so the patient will have low systemic vascular resistance, and compensatory increased sympathetic activity, they will increase the heart rate. So it will be in hyperdynamic circulation and cardiac output will be high. So these are the various hemodynamic variables in different shock states. Next, we will discuss a few case scenarios. The first case scenario is a 55-year-old gentleman. He came to ER, he has symptoms of pain, abdomen, vomiting. On examination, the patient is febrile, tachycardic, tachypneic, peripheries are warm. There is diffuse tenderness in abdomen, guarding and rigidity are noted. So we are suspecting the peritonitis for exploratory laparotomy. When coming to shock, since the peripheries are warm here, we should consider differentials of first will be distributive shock, maybe septic shock. The other differentials can be because the patient has peritonitis, he has a lot of dehydration and third spacing, because of which the patient might be having an hypovolumic shock. So in distributive shock, the patient will have low SVR, high cardiac output, high heart rate and tissue hypoxemia. Coming to the pathophysiology of distributive shock, in this I'll be mostly talking about sepsis and anaphylaxis. In sepsis and anaphylaxis, because of the endotoxins in sepsis, there is systemic inflammation, increased vessel permeability. The fluid is leaking from intravascular space into the extremities. There is warm extremities, but there is, because of the shift of the fluid, intravascular volume has decreased, venous return to the heart has come down, stroke volume has come down, and patient will have a low cardiac output state. There is another distributive shock, neurogenic shock. In the neurogenic shock is seen when there is an injury to the cervical spine or thoracic spine above T4 level. The sympathetic nerve connection below the cervical spine are disrupted. So there is profound vasodilation that will cause decreased cardiac output. In addition to it, the vagal tone is uninhibited, because of which the patient has bradycardia. The note to be maintained is this is the only type of the shock where we can see bradycardia. So when there is a decreased cardiac output, there is insufficient organ perfusion. So there is oxygen utilization has also come down. So in the brain, the patient will have altered mental status. Heart, it can cause myocardial ischemia. Kidneys, the patient might go into AKI, acute tubular necrosis and oliguria. In the peripheral skeletal muscle system, the aerobic metabolism will be converted to anaerobic metabolism. So there is an increased lactic acid production, lactic acidosis. And in the heart, because of the sympathetic activation, patient might have a tachycardia. So the management of septic shock, these are based on the 2021 surviving sepsis guidelines. It has to be early goal-directed therapy, multifaceted approach involving perioperative physicians, anesthetists, emergency physicians, surgeons, and critical care physicians. So initially, we should start resuscitating the patient with 30 ml per kg IV fluids within first 3 hours of resuscitation. Now we need to see about dynamic parameters rather than static parameters like stroke volume variation, pulse pressure variation, or echo if available, that should be used to monitor the patient. Serum lactates have to be immediately sent, and we should aim at decreasing the serum lactate levels. If the patient is on vasopressors, we should not aim at a higher target. MAP of 65 is sufficient. The patient should take immediate blood set of cultures, and it should start antibiotic therapy. In fluids, crystalloids is the first line of fluid for resuscitation. Among crystalloids, balanced crystalloids are preferred over normal saline. The patient is receiving large amount of crystalloid, we can consider albumin. It is recommended against the use of starches and gelatin. When coming to vasopressor, norepinephrine is the first line of agent over the other vasopressors. Even with noradrenaline, if you are not able to maintain the blood pressure, we can add vasopressin. As a third line of agent, we can add epinephrine. It is suggested against the use of terlipressin. If the patient is already on dual vasopressor support, we can consider adjunct IV hydrocortisone like steroids. Angiotensin 2 is a recent drug. It is still in trials. The data is not sufficient yet to include in the management. So when the patient is early severe and he enters a stage of refractory shock, then the rescue therapies, we can initiate methylene blue bolus followed by an infusion or hydroxycobalamin. There's a second case scenario. A 24-year-old ASA2 patient, he is a symptomatic cholelithiasis. He's planned for laparoscopic cholecystectomy. The patient gives a history of bronchial asthma. We have induced and intubated the patient. Then we notice the patient has developed urticarial rash, increased airway pressures, hypotension, and tachycardia. In this case scenario, because of the urticarial rash and hypotension and tachycardia, we should think the patient might have developed an anaphylactic reaction to any of the drugs we have given. The second differentials we have is the patient has a history of bronchial asthma. So he might have developed a severe bronchospasm. So anaphylactic shock is a severe, potentially life-threatening allergic reaction. It occurs after rapidly exposure to an allergen. It has widespread immune system activation. There is a large amount of inflammatory mediators and histamine release. It will lead to rapid multi-organ system failure. When we come to pathogenesis, there are three pathogenesis that have been explained in anaphylaxis. One is immunological IgE dependent, second one is immunological IgE independent, and third one is non-immunological. So when the patient we have been exposed to the drugs or any allergen, first there is an immunological IgE dependent pathway. The antigen is exposed to the antigen presenting cells. These antigen presenting cells present the antigen to T helper cells. This T helper cell will stimulate the B cells to form into plasma cells that will produce IgE immunoglobulin. This IgE immunoglobulin will bind onto the mast cell with the help of FCERA receptor. On re-exposure, there is cross-linking of antigen with the receptors and there is mast cell activation. If it is IgE independent, this antigen antibody complexes, they'll cause indirect complement system activation. They'll release C3a, C4a, C5a peptides that will also cause mast cell activation. Third, there is non-immunological, exercise or environment directly will stimulate mast cell activation. When there is a mast cell activation, there is a release of mediators, but we have seen there is a biphasic response. There is an immediate phase and a late phase. In the immediate phase, there is release of histamine, prostaglandins, leukotrienes, platelet activating factors, and other inflammatory cytokines. All these mediators will cause severe vasodilation. They increases the vascular permeability. They cause smooth muscle contraction in the form of bronchoconstriction, increase mucus secretion, and this is a autonomic nervous system activation. Late phase occurs minutes to hours. So all these patients have to be kept in monitoring in the emergency department for 6 hours. The various symptoms are because of the smooth muscle contraction in GI, patient might have abdominal cramp, vomiting, diarrhea. He might have bronchospasm, wheezing, superficial vasodilation, flushing, systemic vasodilation causing hypotension and circulatory collapse. And increased vascular permeability and fluid leaking in the superficial dermis might cause urticaria, and in deeper dermis can cause angioedema. So we'll diagnose anaphylaxis when any one of the three conditions are met. There is an acute onset of skin or mucosal involvement with respiratory compromise and hypotension. Rapid onset of symptoms after exposure with two of the four symptoms: skin or mucosal symptoms, respiratory symptoms, hypotension, persistent GI symptoms. Hypotension after exposure to known allergen. So a note to be made that we don't need urticarial rash in all the cases of anaphylaxis. It can be present without having an urticarial reaction on the skin. Treatment: whenever we have diagnosed anaphylaxis, the immediate first drug of choice is epinephrine, 1 in 1000 IM every 5 to 10 minutes in the anterolateral aspect of the thigh. It acts on alpha-1 receptor on the blood vessels, will cause vasoconstriction. It acts on beta-1 receptors in the cardiac muscle, increases the cardiac contractility and heart rate, blood pressure will increase. It acts on beta-2 receptors on bronchial smooth muscle and cause bronchodilation, improves the ventilation. The adjunctive therapy in the form of antihistaminic cetirizine, competitive H1 antagonist, and will decrease the angioedema and urticaria. Salbutamol can also use for bronchodilatory. Steroids can be considered to prevent the late phase reaction, and the patient should be monitored for 4 to 6 hours. We should follow up with the family physician to see if the patient has any other history. So in our institute, while we are giving the anesthesia, we avoid multiple drug administration at the same time. So we don't give any adjuvants like dexamethasone, pantoprazole or antibiotics at the time of induction. Whatever the induction drugs are required, we'll only administer those drugs. And once the patient has been intubated and settled, then we will go and give the antibiotic dose. This is a third case scenario. A 65-year-old female patient presented to the ER. He has chest pain and heaviness in chest. On examination, she is tachycardic, hypotensive. ECG shows ST elevation in anterolateral lead. So this is a typical case of angina with cardiogenic shock. So cardiogenic shock is a low output state due to primary cardiac dysfunction that is leading to systemic decompensation, end organ dysfunction, and secondary myocardial injury. The hallmarks of cardiogenic shock are: there is a known cardiac dysfunction, SBP is less than 80 to 90, cardiac index is less than 1.8 liters per minute per meter squared without support, with support less than 2.2 liters per minute per meter squared, and signs of tissue hyperperfusion are present. Mortality is around 40 to 67%. So Society of Cardiovascular Angiography and International have classified into 5 categories, that is A, B, C. A is at-risk patient. The patient will have normal CVP, no rails, warm and good peripheral pulses. He'll have normal biochemistry labs. Lactates are normal. Renal function is well preserved. Blood pressure is more than 100. Cardiac index is more than 2.5. CVP is less than 10. These patients are at risk. Beginning of the cardiogenic shock, the patient will have an increased CVP. He will have good mental status, good peripheral pulses. Minimal renal function impairment, elevated brain natriuretic peptide. SBP is less than 90, MAP is less than 60 or more than 30% decrease. Patient will have heart rate more than 100. So there is a clinical evidence of hypotension or tachycardia, but there is no hypoperfusion yet. So there is a classic cardiogenic shock. So the patient will have clinical signs of hypoperfusion also, which will need intervention either pharmacologically or mechanical circulatory support. So the patient will look very unwell. He'll have volume overload, pulmonary edema. Lactates might be more than 2. GFR has decreased by 50%. SBP is less than 90. Cardiac index is less than 2.2. Deteriorating or doom, any stage of stage C, and it is still deteriorating. He is not responding to the vasopressor or mechanical circulatory support, that is deteriorating stage. Extreme stage is almost nearing the cardiac arrest. There is no blood pressure without resuscitation, no response, sustained ROSC, pulseless electrical activity or refractory VTAC. So what are the causes of cardiogenic shock? Can be divided into ischemic and non-ischemic. Ischemic is acute MI, mechanical complication of ischemic infarct. Non-ischemic is acute on chronic heart failure, acute decompensated heart failure. For a peri-op physician, the most common conditions are stress-induced cardiomyopathy, pregnancy-associated heart disease, peripartum cardiomyopathy, post-cardiac arrest myocardial stunning, septic cardiomyopathy, dynamic LVOT obstruction with HOCM. These are most commonly seen in perioperative setting. So Forrester has classified the cardiogenic shock into 4 categories based on the cardiac index and pulmonary capillary wedge pressure. So if the patient is having cardiac index more than 2.2 and pulmonary capillary wedge pressure is less than 18, so the patient is warm and dry, it is Forrester class 1, it has a minimal mortality. In this Forrester class 2, the patient has a cardiac index is more than 2.2, but his pulmonary capillary wedge pressure is more than 18. That means the patient is having pulmonary edema and we should start therapy for pulmonary edema. In Forrester class 3, the cardiac output has come down. It is less than 2.2, but the lungs are still dry. Pulmonary capillary wedge pressure is less than 18. So in this situation, the patient is underfilled. We can still give a fluid resuscitation for this patient. In Forrester class 4, the patient cardiac index is also low and pulmonary capillary wedge pressure is also high. The patient is cold and wet. So this is patient is already fluid overload and has a decreased cardiac output. We should consider vasopressors and inotropes. So whenever there is a myocardial dysfunction, it can be in the form of systolic and diastolic. Systolic myocardial dysfunction will have decreased cardiac output, decreased stroke volume, that is reducing the systemic perfusion. There will be compensatory vasoconstriction. There is hypotension, decreased coronary perfusion, that in turn will cause ischemia. In diastolic dysfunction, there is elevated left ventricular end diastolic pressure. There is pulmonary congestion that will cause hypoxemia. Hypoxemia will further will further worsen your ischemia. In addition to the systolic and diastolic dysfunction, there is activation of systemic inflammatory system, the release of inflammatory cytokines and nitric oxide, which will cause vasodilation and might further decrease your SVR. This entire thing is a vicious circle. So in symptoms, if the patient has a right-sided heart failure, he'll have lower limb edema, sacral edema, hepatomegaly, increased JVP, regurgitant murmur in the tricuspid area. If he is having hypoperfusion, cool peripheries, cyanosis, orthopnea, and delayed capillary refill time. If the patient is having left-sided heart failure, he'll have lung crackles, respiratory wheeze, displaced cardiac apex, and left-sided heart murmur. The diagnostic tests available are ECG. We can see the area of ischemia and which coronary circulation has been affected. Chest X-ray to rule out pulmonary edema. Echocardiogram will help us in diagnosing the cardiogenic shock, seeing the complications of acute MI, ventricular size and function, valvular functions, filling pressures, and measuring the cardiac output. So cardiac enzymes and biomarkers to rule out ischemia, we can send elevated troponin IT, CKMB, brain natriuretic peptide, serum lactate. For monitoring, we use routine standard ICU monitoring. Along with the routine standard ICU monitoring, we can use intra-arterial blood pressure monitoring and pulmonary arterial catheter, Swan-Ganz catheter. This will help us to know out the pulmonary capillary wedge pressure that will help in diagnosing and treating the cardiogenic shock. So the goals of management of a cardiogenic shock is to restore the perfusion to the myocardium and end organs while treating the underlying cause of failure. Definitive therapy should not be delayed once the diagnosis is apparent. So what we should, if the patient present with acute pulmonary edema, we should give IV furosemide 0.5 to 1 milligram per kg, oxygen if required intubation, nitroglycerin 10 to 20 mics per minute IV if SBP is more than 100 millimeters of mercury. Second line, if check the blood pressure, if systolic BP is more than 100, then we can consider ACE inhibitor. But we should aim at optimizing the preload. So hypovolemia have to be corrected, administered IV fluids, blood transfusion if required, target hemoglobin more than 10, case specific intervention. And optimize afterload. If the patient is having low output, check the blood pressure. If the systolic blood pressure is more than 100, we can consider nitroglycerin. If it is 70 to 100 and there is no evidence of hypoperfusion, we can consider dobutamine. If the patient is having 70 to 100 and there is hypoperfusion, we can consider dopamine. If it is less than 70 millimeters of mercury, then norepinephrine is the vasopressor of choice. Then we should optimize the rate and rhythm. So if the patient is having brady or tachycardia, we have to treat as per ACLS guidelines. So the management, the first emphasis has to be given on revascularization. Early revascularization will restore the blood circulation to the heart and it will improve the function. Medical treatment in the form of vasopressors and inotropes, I have explained in the previous slide. Mechanical assist device. The mechanical assist device that are used are intra-aortic balloon pump, Impella, or we can use ECMO depending upon the indication. So obstructive shock. The etiologies of obstructive shock are impaired preload or diastolic filling or elevated afterload. So impaired preload or diastolic filling is seen in mediastinal tumors. More common for us are tension pneumothorax, hemothorax, cardiac tamponade, constrictive pericarditis, severe pulmonary hypertension, massive pulmonary embolism, high-grade abdominal compartment syndrome. Elevated afterload for right ventricle is seen in massive pulmonary embolism and severe pulmonary hypertension, coarctation of aorta. So in pathogenesis, the cardiac tamponade, there is fluid in pericardium, there is increased pericardial pressure, it's compressing all the chambers of the heart, decreasing venous return to the heart. In pulmonary embolism, there is obstruction to the pulmonary blood flow, increased right ventricular afterload, decreased right ventricular stroke volume, underfilled left ventricle. In tension pneumothorax, there is an increased pressure in pleural cavity, the intrathoracic pressure is becoming more than venous filling pressure, which decreases the venous return to the heart. All of them will cause decreased cardiac output. So when there is a decreased obstructive shock, the venous pressure will back up. So there will be a rise JVP. Patient will have peripheral edema, dyspnea and tachypnea and evidence of end organ tissue damage. There's a case 4. This is a 35-year-old male patient presented to the ER with a history of RTA and sustained injury to the right leg. No history is suggestive of head injury or any other major injuries. On examination, he is hypotensive, tachycardic, cold peripheries. X-ray of suggestive of shaft of femur fracture. In this case scenario, our first will go towards the shaft of femur fracture and the blood loss. So we think of hypovolemic shock. But we should always keep in mind the patient might be having, and because it is a polytrauma, he might be having a pneumothorax or a hemothorax, might be causing an obstructive shock, or he might be myocardial ischemia and having a cardiogenic shock also. The shaft of femur fractures are also associated with fat embolism, so that should also be kept as a differential diagnosis. Hypovolemic shock is from the loss of intravascular volume. Either it can be a direct loss from the blood or indirectly from extracellular volume loss. If it is loss of whole blood, we term it as hemorrhagic shock. If it is associated with soft tissue injury, we call it traumatic hemorrhagic shock. This distinction is very important because there is an evidence that show if the patient is having a tissue injury, there is disruption of blood endothelium interaction, and that will accelerate our coagulopathy. So the most common cause of hypovolemic extracellular fluid losses. External losses can be in open abdominal procedures, hyperthermia. Internal losses can be because of prolonged NPO times, vomiting, diarrhea, DI. Loss of whole blood, hemorrhagic shock, post-op bleeding, GI ulcers, uterine atony. Traumatic shock includes the presence of soft tissue. When it comes to the pathophysiology, the trauma or dehydration, there is decreased intravascular volume, loss of circulating blood volume, so decreased venous return to the heart, there is hypovolemic shock, which will cause insufficient organ perfusion. So there is end organ tissue damage. In the skin, we'll have cold mortal extremities. Brain, there is decreased mental status. Heart, tachycardia. If there is severe myocardial ischemia, will cause pulseless electrical activity. Kidney, there will be acute tubular necrosis, oliguria, and in skeletal muscles, there will be lactic acidosis. Diagnosis: if the patient is intubated and mechanically ventilated, we can see the PPV, the pulse pressure variation. More than a single value, the trend in pulse pressure variation will help us in resuscitating the patient. Similar to it, CVP also will guide us in resuscitation. Arterial blood gas analysis to see the lactate. IVC assessment can be done with ultrasound. So when we are doing the IVC assessment, the normal IVC diameter is 1.5 to 2.5 centimeters. If it is less than 1.5 centimeters, the patient is underfilled. We have to give fluid resuscitation, give crystalloid. If it is more than 2.5 centimeters, that means the patient is overload. We restrict the fluids. If it is between 1.5 to 2.5 centimeters, we need to see if the patient is intubated or not intubated. If the patient is intubated, then we can calculate collapsibility index. Collapsibility index is diameter maximum minus diameter minimum divided by average into 100. If it is more than 12%, the patient will require fluids. The patient is not intubated, then IVC cannot help us in guiding the fluid. We'll do a lung ultrasound. In the lung ultrasound, if there is an A line, there are no B lines, we can give a fluid challenge test. The patient is having B lines, it means there is a fluid overload. We need to restrict the fluid. So there is EFAST. EFAST has to be done in the emergency department to rule out the hemoperitoneum. So there are 5 quadrants in which we check for the EFAST. First one is the right upper quadrant. It is seen in between right lobe of the liver and the right kidney. It is also called as Morrison's pouch. If any fluid has been detected here, that suggests to a hemoperitoneum. The second is left upper quadrant. We have to see in between the spleen and the left kidney. That is perisplenic space. The third view is pelvic view. In the female patient, if there is any fluid between the recto-uterine pouch or pouch of Douglas. In male, in rectovesical pouch, any fluid we have to see for any fluid is there. Fourth view is subxiphoid view to rule out pericardial effusion. The extended version of it is we can screen the lung to see for any pneumothorax. There is any loss of C-code sign or barcode sign that is suggestive of pneumothorax. So any recognized adult patients, maximize oxygenation, protect the airway. ABC has to be taken care. Then do EFAST. If any treatable emergency causes are there, initiate treatment. like cardiac tamponade, start doing pericardiocentesis, pneumothorax, do thoracostomy, hemoperitoneum, emergency laparotomy. If any pelvic instability is there, pelvic binder, control the external hemorrhage either by applying direct pressure or tourniquet. Establish IV access. Two large widebore IV access have to be established. If they are not available, we can alternate intraosseous or central venous catheters can be placed. Obtain blood for type and cross matching, and whenever indicate, we will start massive transfusion protocol. Perform initial studies to identify the bleeding and injury sites. We can take chest X-ray and CT depending upon the history. We should avoid the lethal triad of trauma, that is coagulopathy, acidosis, and hypothermia has to be avoided. There's a quadrant, that is we should avoid hypocalcemia, and the pentad is we should avoid hyperkalemia in all. So as to summarize all the slides, so when a patient comes to us with a shock that the patient is having ill appearing altered mental status, tachycardia, hypotension, metabolic acidosis, tachypnea, and oliguria, then we should immediately start resuscitating, take caring of ABC, we should get an IV, start oxygen, vital signs, correct any emergency causes of the shock like pneumothorax, hemothorax, tamponade, pulmonary embolism, stop the hemorrhage, and fluid resuscitate. Then we need to evaluate the cause, whether it is cardiogenic, hypovolumic, or undistributed, based on the history, ECG, chest X-ray, ultrasound. And the treatment has to be followed according to the algorithm. A short note we should make that all these shocks are not exclusively. Sometimes the patient can be present with a combination of shocks. For example, if the patient comes with sepsis, the septic shock will cause severe vasodilation, myocardial ischemia, and that patient might develop myocardial dysfunction. The sepsis itself can cause myocardial dysfunction. So there might be an overlap of septic shock with cardiogenic shock in. Sometimes the patient might come with polytrauma, so he might be having severe blood loss and hypovolumic shock. Along with it, the patient might have a pneumothorax that might cause obstructive shock, or he might have a cardiac tamponade having an obstructive shock. He might have a fat embolism or a pulmonary embolism that might also cause obstructive shock. So there might be an overlap of all these shocks together. So we should initiate ABC, treat the emergent causes, and then should slowly evaluate the cause of the shock.
Sir, any comments?
Very lucid talk. Nowadays, the important when we talk about hemorrhagic shock is a tranexamic acid. Based on the evidence available, we have different trials. Crash 1 trial, the role of steroids in trauma, mortality, Crash 1 trial. In the Crash 2 trial, they gave tranexamic patient with hemorrhagic shock, that is 1 gram within 8 minutes, 10 minutes. Next 1 gram for 8 hours. And then they found mortality benefit. And Crash 3, we know the role of tranexamic acid in traumatic brain injury, moderate traumatic. So the tranexamic acid is one thing. And the other thing is ultrasound, as you rightly said, the focus point of care ultrasound, whatever protocol you use, most commonly used protocol is the rush protocol, rapid ultrasound shock patients. And ultrasound is not only is used to identify the type of shock, and it is useful in monitoring also later when you are giving fluids, whether A lines are becoming B lines, have a false protocol. Next, when you are giving fluids, what is happening, we can monitor. And then sometimes it helps in treating the shock patient. If you have a patient with sepsis, septic shock, when you use ultrasound, if the patient has cholecystitis, and if that is the source, and then we can put a ultrasound percutaneous cholecystotomy we can do, or if the patient is having empyema, we can do ultrasound guided aspiration. So it helps in managing the shock also, correcting the, finding out the etiology and correcting the problem. Otherwise, you covered most of the points, and as you rightly said, there's sometimes overlap of shock, different shocks, and then so that we should not be focused on only one shock. When you get a trauma patient, don't think that it is always hypovolemic shock. Yes, it is hypovolemic shock, along with hypovolemic shock, you may be having obstructive shock like pneumothorax, or you're having cardiac tamponade. Sometimes even in septic patients will have empyema, or when a patient can have cardiac tamponade, pus may be there. We have to.
Sir, I have a question for you. Vasopressor or inotrope of choice in neurogenic shock with the bradycardia and hypotension.
For all shocks, we know the first drug of choice is norepinephrine. In septic shock, especially, we add vasopressin early, and then sometimes we use epinephrine, third choice. And then we use dobutamine whenever when cardiogenic shock. Definitely in the neurogenic shock, even in neurogenic shock, the first line of vasopressor adrenaline. For all the shocks, the first drug is norepinephrine. But whenever there is bradycardia, so we can use adrenaline, epinephrine, or we can use to increase the heart rate. We can go for chemical pacing like supranolol. And then the phenylephrine again may cause intense vasoconstriction. So we can use epinephrine or even norepinephrine if the heart rate.
Sir, I have one more basic question for you. This is for audience sake, actually, viewer sake. Actually, what is the vasopressor or inotrope of choice for a septic patient who is in septic shock with a background of peripheral vascular disease like Takayasu, arthritis? So, what is your choice?
It is a difficult question. So definitely when you're using vasopressin, we have to be very careful. And if the patient has a septic shock, again, maintaining the major organ perfusion is something which is very important. And we still go with norepinephrine, but try to avoid vasopressin, other vasopressors. Then at some stage we can use based on the SCO2, we can use even dobutamine in those patients.
Okay, sir. Thank you for your inputs. With this, we'll move on to next topic. Perioperative management of acute stroke by Dr. Shirisha. She did her DNB from Yashoda Super Specialty Hospital, and she is currently working as a consultant at AIG Hospital in the anesthesia department. Over to Shirisha.
Good afternoon, everyone. My presentation is on perioperative stroke management and prevention. So here are some clinical scenarios which Here are some clinical scenarios which we encounter daily in our day-to-day practice. So a 75-year-old man presents for total knee replacement, severe osteoarthritic pain, history of ischemic stroke 2 months ago. He has mild residual weakness in the left hand and history of atrial fibrillation and takes warfarin. The second clinical scenario, a 82-year-old man presents for TURP, that is transurethral resection of prostate, needed an emergency catheterization for acute urinary retention, and old ultrasound report showed large prostate with significant post-void residue. He is a known case of CAD and systemic hypertension, and the BP is around 210 by 109 at the time of catheterization, and the patient is on 3 antihypertensives. The third case scenario is a 68-year-old man presents for right liver resection segment 5 and 6. He is a known case of hypertensive on Telma 40 mg BD and Metexel 25 mg BD, and on examination carotid bruit was present, and carotid Doppler showed 50% right carotid artery occlusion, and the surgeon requested to maintain low CVP and hypotensive anesthesia. The fourth clinical case is 43-year-old posted for pancreatic adenoma. Lab lateral pancreatectomy with splenectomy was done under general anesthesia, and the surgery was uneventful. And on first POD, the patient complained of right hemiparesis, and the patient had history of moderate to severe COVID in 2020. So when a patient comes for a pre-anesthetic checkup, so to prevent stroke, so we need to identify the patient with risk factors for perioperative stroke, implement perioperative optimization strategies for high-risk patient, discuss the issues related to the post-operative screening and management of the stroke, and discuss recent evidence about the frequency and sequel of silent ischemia or called covert perioperative stroke. So coming to the definition, the stroke may be an embolic, thrombotic or hemorrhagic cerebrovascular event. The clinical deficit lasting at least 24 hours before surgery. Intraoperative or within 30 days of postoperative period, and the risk of perioperative stroke is around 0.1 to 1% in case of non-cardiac and non-neurological surgery. So most of the perioperative strokes are ischemic. Higher rates occur in vascular and neurosurgical procedures, and for cardiac surgery, the incidence is approximately 1%. So the risk factors for perioperative stroke include patient factors: old age, history of prior stroke or transient ischemic attack, hypertension, history of atrial fibrillation, valvular disease, cardiovascular, renal disease, diabetes mellitus, smoker or COPD, patent foramen ovale, migraine with or without aura. And surgical factors include vascular surgery, thoracic surgery, transplant surgery, endocrine, burn surgery, any bowel involving surgery, and otolaryngeal surgery. And anesthesia factors, these are actually fortunately rare, and sometimes they are interlinked with the surgical procedure also. For example, extreme hemodynamic response during intubation, and any bleeding during surgery, and profound hypoxemia may be due to difficult intubation or any negative pressure pulmonary edema. And impact, what is the impact of perioperative stroke is annually 25,000 cases were detected, and that too in the non-cardiac, non-neurological surgeries, and 30-day mortality rates are around 8-fold higher than controls. The absolute mortality is around 21 to 26%. So they increase the length of the stay in the hospital, and also after discharge they require senior nursing faculty for the recovery of the patient. So silent ischemia, it's also called as covert stroke. So these are acute ischemic events that are not clinically apparent, and they are determined only through MRI or imaging only. So they occur in 30 to 50% in patients undergoing carotid artery stenting or cardiac surgery, 90% in transcatheter aortic valvular replacement, 17% in carotid endarterectomy surgery, 7 to 10% in non-cardiac surgery. And the risk of cognitive impairment in this covert stroke is around 2-fold at 1 year period. So the pathophysiology mechanisms are less clear. 50% occur within first 24 hours, 93% within 72 hours. So suggests intraoperative and early postoperative period is the most critical phase. Coming to the putative mechanisms, so hypotension or any low flow states, undisclosed large artery stenosis, anemia associated tissue hypoxemia, and thromboembolism, fat embolism, enhanced coagulopathy, endothelial dysfunction, and stoppage of antithrombotic medication. Coming to the risk stratification, there is no particular stroke risk tool exists for the non-cardiac surgery. So we can consider using American College of Surgical Risk Calculator, and two other scales are chart score and CHART-VASc risk score. So these were initially validated to predict the stroke risk in patients with non-valvular atrial fibrillation, but now we can use this to predict the perioperative stroke risk in patients undergoing cardiac procedure even in the absence of atrial fibrillation. So the CHART-VASc score includes congestive heart failure, hypertension, age more than 75, diabetes, prior transient ischemic attack or stroke, vascular disease, age in between 65 to 74, and the female sex category. So if the CHART-VASc score is more than 2, so we usually give antithrombotic prophylaxis to prevent perioperative ischemic stroke. Coming to the pre-operative stroke reduction, risk reduction strategies. So timing of the surgery. So any elective non-cardiac surgery can be deferred at least 6 months after a prior stroke and possibly as long as 9 months to reduce the risk of perioperative stroke. If it is going to improve the quality of life, at least a minimum waiting period of 6 months can be considered after a prior stroke. Extracranial carotid artery stenosis. So patients presenting for non-cardiac, non-neurological surgery should be evaluated for the risk factor, one of the risk factor of the stroke, that is carotid stenosis. So if the patient is symptomatic and there is a high grade stenosis, that is 50 to 99%, so it is better to go for carotid endarterectomy before an elective procedure is planned. And in case of asymptomatic patients, the relative risk and benefits are not that proven. And intracranial stenosis, small retrospective study of 38 patients with high-grade vertebrobasilar stenosis had perioperative stroke of 6% and no evidence to support prophylactic intracranial stenting prior to non-cardiac surgery. And patent foramen ovale, a retrospective study of 150,000 patients undergoing non-cardiac surgery revealed higher perioperative stroke rate in a patient with patent foramen ovale. And the strokes tend to be more severe and in large vessel territory in a patients with patent foramen ovale. And interatrial septal aneurysm, if it is more than 10 mm, they are also associated with a higher risk of perioperative stroke. And coming to the pharmacological management, beta blockers. So, actually, several conventional studies have suggested that initiation of beta blockers prior to surgery can decrease cardiovascular and stroke risk. But the new study suggests that initiation of beta blockers prior to the surgery increases the risk of stroke. So it is not advised to start the beta blockers immediately before surgery. And in contrast, chronic beta blocker therapy, who the patients who are on beta blocker already on beta blocker therapy, they can be continued on the day on the day of the surgery. Coming to the statins, so continue statins to reduce cardiovascular events, though there is no proven in case of perioperative stroke reduction. And antithrombotic therapy, so bridging anticoagulation is recommended, balancing the risk versus benefit considering perioperative bleeding and thrombosis. So according to the perioperative thromboembolism, we can categorize it as high risk. So any mechanical heart valve like mitral valve prosthesis or recent stroke within 6 months or any transient ischemic attack and atrial fibrillation with chart score of 5 or 6 and any recent venous thromboembolism and protein C, protein S deficiency or antiphospholipid deficiency, and moderate risk involves bileaflet aortic valve prosthesis and atrial fibrillation prior stroke or transient ischemic attack and the chart score of 3 or 4 and venous thromboembolism within the past 3 to 12 months and non-severe thrombophilia and any recurrent venous thromboembolism and active cancer within 6 months or palliative treatment. And low risk involve the bileaflet aortic prosthesis without atrial fibrillation and the chart score of 0 to 2 and venous thromboembolism more than 12 months previously and no other risk factors. So depending on that, we can plan antithrombotic medication, and the perioperative antithrombotic medication management was previously told by Dr. Manjusha in the part 2 webinar series. Coming to the blood pressure, so maintaining end organ in this intraoperative management, coming to the blood pressure management in the intraop. So maintaining end organ pressure is very critical, especially the brain. So and the perioperative ischemic evaluation, that is POISE study. So it has shown that higher stroke rates seen in patient receiving metoprolol. So stronger evidence showing association between hypotension and end organ damage and the mean arterial pressure of more than 70 mm intraoperatively to reduce the risk of stroke in both cardiac and non-cardiac surgery. So no specific upper map target is advised, but just avoid extremes of hypertension to limit end organ injury. And goal directed therapy, it's more complex hemodynamic management targeting optimal organ perfusion and oxygen delivery, and the studies using cardiac output guided or hemodynamic algorithms reduced overall complications. Coming to the blood transfusion, So the oxygen delivery to the brain is a function of cerebral blood flow and arterial oxygen saturation and hemoglobin. So anemia appears to be a risk factor for stroke. So according to American Association of Blood Bank transfusion, threshold of 7 gram per deciliter for stable patients and less than 8 gram for patients with cardiovascular disease or hemodynamical instability, and less than 8 gram threshold for patients with elevated stroke risk, and less than 9 gram per deciliter with acute perioperative stroke or large vessel stenosis is advised, and hematocrit of 28 or above is sufficient for a good oxygen delivery. And coming to the choice of anesthetic monitoring techniques, so there is no currently insufficient evidence to support the use of regional or general anesthesia. It depends on, it varies from patient to patient and different clinical scenario. So there is no particular this study showing which is beneficial in the patient. So in patients who are indeed undergoing high risk procedures like carotid endarterectomy, neuromonitoring techniques such as electroencephalography and somatosensory potential monitoring allow detection of intraoperative ischemia. And assessment of regional cerebral oxygenation is an additional intraoperative neuromonitoring technique where infrared spectroscopy is used to indirectly measure cerebral tissue oxygenation. And ventilation strategy, there is no substantial evidence that hyperventilation and hypocapnia lead to significant reduction in the cerebral blood flow. And the data suggests that avoiding hypocarbia in high-risk patient is reasonable, and that hypocapnia may be exceptionally harmful in the patients with cerebral ischemia. And coming to the identification of perioperative stroke, the stroke recognition, that is between 4% and 17% of all strokes occur in patients who are already hospitalized for either medical or surgical indication, and 60% are either peri-procedural or occur in angiography suite. So half of all perioperative strokes occur within 24 hours after surgery. So identification after surgery is very difficult as it is complicated by residual anesthetic effect, opioids or other psychoactive medication. So post-operatively, there is no validated tool for the detection of the perioperative stroke. So all perioperative providers should be empowered to call a code stroke and implement an established protocol. So this is the protocol. So within the window period is around 4.5 hours where the tissue plasminogen thrombolysis can be given, and according to Dawn protocol or diffuse 3 using CT perfusion studies and MRI studies, so we can do mechanical thrombectomy up to 24 hours. So in our hospital, whenever a patient is detected with acute ischemic stroke, immediately code stroke is activated, and the point of contact is 8888. So within 5 to 10 minutes, the patient is rushed to the imaging department, and MRI is done, diffusion weighted MRI, and the thrombolysis is immediately initiated within the 1 hour. So all patients should undergo imaging to evaluate for intracranial hemorrhage. So non-contrast head CT is more effective, and MRI can be done in instances in which the onset of symptoms is unclear, and non-vessel imaging is recommended for patients who meet criteria for mechanical thrombectomy. So CT angio has been shown to be more accurate when compared to the MRI angio. The Alberta Stroke Program Early CT Score, that is aspects, it measures early extent of ischemic changes on the imaging. So when applied to the non-contrast CT, it correlates with the extent of final infarct on the following patients with a large vessel occlusion. And a normal brain has aspects of 10, and the score falls as more areas of the brain is involved, and a complete middle cerebellar artery infarct would have a score of 0. So additional workup of blood glucose to rule out any hypoglycemia, and troponin ECG, 2D echo to rule out any cardiac event. Hypotension and hypovolemia should be avoided, and if the patient is undergoing thrombolysis, so systolic blood pressure should be maintained less than 185 and diastolic less than 110 to decrease the risk of hemorrhagic transformation of the stroke. And temperature control is also important as hyperthermia can precipitate stroke. So coming to the thrombolytic therapy, so several retrospective studies have shown that perioperative patients undergoing thrombolytic therapy had an increased bleeding at the surgical site. So a recent study which involved 134 patients, they were treated with IV tissue plasminogen activator after undergoing surgery. in prior 90 days. So out of that, 7% had surgical site bleeding and 9.7 had intracranial hemorrhage. All were asymptomatic. So it's really challenging. The use of thrombolytic therapy, including the extended window protocol, may be considered in perioperative patients, but only after careful consideration and discussing with the team. And endovascular therapy, the benefits are clearly established in acute stroke patients presenting with emergency department. Limited evidence in perioperative setting, especially non-cardiac surgery. Extended time window and lack of specific requirements for anticoagulation or thrombolytic treatment. So they afford greater options for endovascular therapy in the perioperative setting. So the goal of mechanical thrombectomy is to achieve reperfusion of the infarcted territory, particularly the large vessel occlusion, and direct aspiration thrombectomy was found to be non-inferior to stent retriever in the patients meeting the same criteria. So post-thrombosis, thrombolytic therapy or post-mechanical thrombectomy, patient may develop cerebral edema. So if significant, he may have to undergo decompressive hemicraniectomy. And dysphagia also should be ruled out to prevent aspiration in the post-operative setting. And post-thrombectomy in hospital management include early institution of secondary prevention measures, that is aspirin. It should be started within 24 to 48 hours of symptoms or 24 hours after fibrinolytic therapy. And the chance and point trial, that is clopidogrel in high risk patients with acute non-disabling cerebrovascular event, and point study is platelet oriented inhibition in new transient ischemic attack trial, have demonstrated the efficacy of dual antiplatelet with aspirin and clopidogrel for 21 days to reduce the ischemia up to ischemic stroke up to 90 days after the initial event in the patient. So coming back to the clinical picture, so in this case we can see the patient is posted for a elective surgery with a recent stroke. So in this scenario, we can postpone the surgery because it's purely an elective case. And for pain management, we can the patient can go ahead with pain therapies like intra-articular injection or any peripheral nerve blocks. And in the second case scenario, we can see it's an emergency procedure. The patient is posted for emergency catheterization, and the patient is a known case of CAD and with uncontrolled blood pressure. So this patient is also at risk for developing acute ischemic stroke or hemorrhagic stroke, maybe due to uncontrolled blood pressure. So first, before taking for him surgery or catheterization, so we need to optimize the blood pressure and continue echosprin throughout the peri-op period, and we can maintain blood pressure around MAP around more than 65, and we can go ahead with the procedure. And for anesthesia, we can give saddle block. Next case scenario, it is right liver resection. It's a major surgery where fluid shifts and major hemorrhage bleeding is expected, and the surgeon and the patient is already hypertensive with carotid bruit, and carotid artery occlusion is around 50%. So this patient is more prone for acute ischemic stroke, and the surgeon is requesting low CVP and hypotensive anesthesia. So in this, we have to discuss with the surgeon and target MAP around 65 to 70 mm of Hg, and it's a goal directed therapy. So we can we can plan this tissue perfusion and oxygen delivery with the goal directed therapy, and activate massive transfusion protocol if required, and blood can be given if there is a massive bleeding, and activate massive blood transfusion protocol. And in case of any hypotension, so calculate the allowable blood loss and substitute with IV fluid, keeping on mind the CVP levels. And next case scenario is pancreatic adenoma and posted for surgery. He underwent left lap lateral pancreatectomy, and POD1 he developed right hemiparesis. So this patient had history of moderate to severe COVID in 2020. So one of the cause may be it's a post-COVID patient. He may be like it may be a thrombotic state. So perioperatively or before procedure, if we might have given low molecular weight heparin, this event could have been prevented. So take home message, if any patient is coming for the surgery, so evaluate the patient, find out the key risk factors, timing of the surgery relative to prior stroke, overall find out the overall cardiovascular risk, type of surgery planned, and the presence of any PFO or interatrial septal aneurysm. So and consider delay of elective surgery at least 6 months and preferably 9 months from time of incident stroke. Perform carotid revascularization in a patient with symptomatic carotid artery stenosis before a planned elective surgery, and use or adjustment of medications such as statins, beta blocker, antithrombotic agents should be based on existing guidelines but tailored to the individual patient characteristics. Intraoperatively, consider maintaining a mean arterial blood pressure of more than 70 mm, especially in a patients who are at moderate or high risk for perioperative stroke. And it is reasonable to consider transfusion threshold of 8 gram per deciliter. And in a patients with high risk of hemodynamic instability and cerebrovascular insufficiency or any attributable to stenosis or occlusion, we can maintain a transfusion threshold of 8 to 9 gram hemoglobin. And there is insufficient evidence to make clear suggestion on the use of general anesthesia versus regional anesthesia, and it is reasonable to consider a lung protective ventilation strategy as a part of overall to prevent post-op complications. And hypocarbia should be generally avoided in the patients at risk of perioperative stroke, and the risk of perioperative stroke less than 30 days is higher within first 72 hours after surgery, with the first 24 hours carrying highest risk and offering the greatest challenge, because identification of symptoms post-operatively is very difficult because of the lingering effects of the procedure and anesthetic medications. And the restoring blood flow to the injured brain is critically important. Patients with a perioperative stroke should be strongly considered for evaluation of mechanical embolectomy and intravenous thrombolysis. So mechanical thrombectomy is preferable to intravenous thrombolysis alone in large vessel occlusion stroke. Obtaining more advanced imaging initially, including CT angio and perfusion study, should be considered to determine the eligibility for mechanical thrombectomy. At the risk of bleeding at the surgical site must be considered in relation to the intravenous thrombolytic therapy.
Subbareddy sir, any comments or inputs, please?
Good talk. Perioperative stroke, when you're taking, you're doing pre-anesthetic evaluation, and there are some surgeries where the risk of stroke is very high, particularly the cardiac surgery, or if the patient is based on the chart score, again you can have stroke. And particularly the patients who are undergoing neurosurgery, post neurosurgery, they can develop a stroke. So this is very important. When you are taking consent, you need to tell the patient what is the incidence of stroke in these patients. Then we will not have any issue later. Pre-anesthetic, proper pre-anesthetic checkup, and then consenting. Later, the patients, what medications they were taking, and as you rightly said, the beta blockers, chronic. The patient is on chronic beta blocker therapy. You need to continue perioperative period. And sometimes when the patient is on antiarrhythmics, the patient may be taking amiodarone for atrial fibrillation, or the patient may be taking flecainide in that matter, and then some people, they try to stop it and then they will forget to reintroduce. Then patients post-operative atrial fibrillation to control. And again, if the patient develops some cardiac ischemia during surgery, then definitely whenever there is cardiac ischemia, the patient is going into CABG. We will not use certain antiarrhythmics like flecainide. So we need to change the antiarrhythmics to prevent the stroke. And we don't do carotid Dopplers for all the surgeries, but cardiac surgeries, we do carotid Dopplers, and based on the carotid stenosis, we do intervention before the surgery. Carotid stenting is very easy, very popular. Not in many hospitals they're doing. So carotid stenting is one thing which can be done before any elective surgery. And coming to mechanical thrombectomy, as you rightly said, there is good evidence for anterior circulatory strokes. If it is a ACA territory stroke, or if it is a MCA territory stroke, we have good evidence. We have DAWN and diffuse trials, and then we can do mechanical thrombectomy up to 24 hours based on the DAWN trial. and that is one thing. And then for all the patients, we need to do imaging. When you get a stroke patient, if you see the guidelines now, before we used to do only CT brain, now we do CT angio to look at the large vessel occlusion. Whenever there's a large vessel occlusion, and definitely we have to go for mechanical thrombectomy, and we have good devices available now. And then it is a priority, and cath lab should be available during that time. And when it comes to IV thrombolysis, yes, we don't do much IV thrombolysis during operative or post-operative stroke. And we have different agents. We have RTPA, and we have Altiplase, and we have Tenecteplase. Both are equally good. Tenecteplase we can give as a bolus, and Altiplase we have to give it as infusion. That is one thing. But when it comes to posterior circulatory, there is a lot of evidence for anterior circulatory. But if there is a vertebral artery stenosis, or if there is a posterior cerebral artery stenosis, what to do, whether to go for mechanical thrombectomy, because the prognosis is poor and the mortality is very high in these patients. So for posterior circulatory strokes, also there are few good trials which are published recently in New England Journal of Medicine. One is attention trial, the other one is plateau study. In the plateau study, in the attention trial, they did not find much benefit with endovascular treatment, but in plateau study, the new trial, they found the patients were getting better when they did endovascular treatment for posterior cerebral artery stenosis, thrombosis. The visual symptoms were getting completely resolved, and the patient vision was improving. So there is still a role for even for posterior circulatory strokes, and the mortality and morbidity is very high in these patients. So we must consider endovascular treatment if it is available in the hospital, or we have to shift the patient to some other hospital within 20 as early as possible for the mechanical thrombectomy.
Sir, any comments on post-operative watershed infarcts?
Watershed infarcts are not when you do imaging, when you do CT or when you do MRI. First of all, when the patient develops weakness after the surgery, we have to see why the patient developed weakness. Is it ischemic stroke, or is it hemorrhagic stroke, or sometimes it is a venous infarct. And in neurosurgery, after the neurosurgery, we see venous infarcts very commonly. But if the stroke, if the hypodensity, if it is hypointense, and that is not particular to any arterial territory, if it is not in ACA territory, or if it is not in MCA territory, if it is in the borderline between the ACA territory and MCA territory, or MCA territory and PCA territory, then we call it as watershed infarct. And the radiologist will help us in identifying these watershed infarcts. But if you look at the pathophysiology of these watershed infarcts, they happen because of hypotension, and they happen because of the patient is having underlying problem like carotid stenosis. So that's why they develop these watershed infarcts. If intraoperatively, if you maintain, and then if you know the risk factors, you have to maintain cerebral perfusion. You have to maintain the maps, and if you have monitors like the NITS monitor, it is not possible to go for ICP monitor, invasive monitors for non neurosurgeries. And most of the cardiac units now, they use near infrared spectroscopy monitor. They measure the regional cerebral oximetry. So these monitors will help us in preventing these watershed infarcts. And if the patient develops watershed infarct, if you maintain pressures, if you maintain the cerebral perfusion pressure, use even transcranial post-operative, the surgical monitor this patient. Still, there is a role for use anti. Definitely, there is no role for thrombolysis in these patients. And even when you do angio, also when you do CT angio, you won't find large vessel occlusions. But watershed infarcts in a lot of patients, like chronic hypertensive patients, we see generally lacunar infarct. In the in the deep brain, we see it's more, the perforating branches will get affected, and then we see lacunar infarcts. The main treatment is maintain the blood pressures, higher MAPs, and antiplatelets we can use in these patients.
This is the maintaining the adequate map intraoperatively to prevent the watershed inbox post-operatively. So though our topic is mainly on acute ischemic stroke, I have a question on hemorrhagic stroke, which I'm very fond of because there is always a controversy around this topic. So a patient on dual antiplatelets comes with a hemorrhagic stroke and posted for a decompressive cranectomy. The anesthetist or whoever is at the head and they'll be thinking whether to transfuse platelets or SDP, single donor platelet transfusion. What is the role? Is there any, what is the evidence showing, what is your experience on this SDP transfusion in a patient on dual antiplatelets with hemorrhagic stroke posted for emergency decompressive cranectomy?
It is emergency decompressive cranectomy. We cannot cancel. We have to go ahead with the surgery. But most of these stroke patients, as you rightly said, based on the two trials, the point trial and chance trial, they are on dual antiplatelets. So we take the patient for decompressive cranectomy, and then there is no routine practice of platelet transfusion in these patients. Even there is no evidence for routine either random donor platelets or single donor platelets. But if you have a if you have a thromboelastogram in your operating room, you can do tech, and tech can guide you about the transfusion protocols. And most of the time, before in our center also, the surgeons used to prefer giving antiplatelets before going for decompressive cranectomy. And then we used to get a call from the blood bank that what is the role of transfusing platelets and all. Now we are not doing that. We are not going for platelet transfusion. We can use TEG. And even in stroke patients, sometimes when the patient has a ischemic stroke or the patient is taking dual antiplatelets after coronary intervention, they come to ICU with a hemorrhagic stroke. So, is there any role for platelet transfusion? There is good evidence. Good study showed that there is no benefit of giving platelet transfusion in these patients with hemorrhagic stroke. Way back when I was practicing 10 years back in the neurointensive care unit, whenever we get a hemorrhagic stroke patient, some neurophysicians, they used to give FFP to the patients, and then they used to give recombinant factor 7A to these patients, and then they used to see thinking that the clot size will not increase. But later in all the studies, they proved there is no role, and there is no you can't prevent the size of the clot even if you give all these medications. So there's no role. And then these medications like FFP transfusions and recombinant factor 7A in the hemorrhagic stroke patients, they were increasing thrombotic complications in these patients. So definitely no role unless your tech shows any evidence of platelets.
Inputs. And let's move on to the next topic. Health and well-being of an ICU physician by Dr. Sarah Paul. She did her MD, followed by fellowship in regional anesthesia from Ganga. Currently, she is working as a consultant at AIG Hospitals. Over to Dr. Sarah.
Good evening. I'll be speaking regarding the health and well-being of ICU physicians. Now, physicians, especially those providing critical care services, are suffering from anxiety and burnout at an alarming rate. This epidemic of burnout has now reached a crisis level. It has driven many physicians to scale back work hours or leave healthcare altogether. Despite increasing fellowship spots and alternative pathways for entry into critical care, there is yearly net loss of critical care physicians. So it's high time we acknowledge the health and well-being of perioperative and critical care physicians. The contributing factors of burnout being women, younger age, trainees, mid-career faculty, increasing patient workloads, long hours, stressful work environment, unsatisfactory work environment, conflicts with colleagues, and administrative tasks. And the consequences being compromised health and well-being of physician, decreased quality of healthcare, medical errors, reduced patient satisfaction, increased cost of care, reduced effectiveness at work, less commitment to job or organization, high turnover and associated costs, difficult interpersonal relationships, loss of mentorship for junior faculty. There are three aspects of culture of medicine that needs to be addressed. This is medical exceptionalism, which is the idea that to practice medicine, a physician should be self-sacrificing. This leads to unhealthy behaviors and unsafe work practices and leaves the physician vulnerable to exploitation by the healthcare system. Medicalization is the notion that physicians with mental health or substance abuse problems are not fit to practice medicine. This prevents them from seeking help for mental health conditions. Individual responsibility, where it is considered solely the responsibility of the physician to maintain their own wellness, wherein low-cost programs that support the physicians are to be considered here. Now, burnout syndrome has become a worldwide phenomenon among members of high-stress professions such as perioperative and critical care physicians. Now, the term burnout refers to a work-related constellation of symptoms and signs that usually occur in people with no prior history of psychological or psychiatric disorders. It is triggered by a difference between the expectations and the ideals of the employee and the actual requirements of the position. The initial symptoms are emotional stress and disillusionment with the job, and later they develop an inability to adapt to the work environment and demonstrate negative attitudes towards their job, their co-workers, and even their patients. There is a triad of classical symptoms, which is emotional exhaustion, depersonalization, and reduced personal accomplishment. Other psychological symptoms include frustration, anger, fear, anxiousness, inability to feel happy, being unprofessional, feeling overwhelmed, hopelessness, lack of empathy, feeling insufficient at work. And physical symptoms include exhaustion, fatigue, insomnia, muscle tension, headache, and GI problems, which eventually results in a physician who questions the value or worth of his or her work and generalize poor professional esteem. Prevalence: physicians are 36% more likely to develop burnout syndrome when compared with other high school graduates, out of which more than 50% are comprises of acute care specialties. Like anesthesiology comprises of more than 50% and critical care around 55%. AHG conducted a survey among doctors wherein 54% of the doctors say that they are burned out. 88% of the doctors say they are moderately or severely stressed, and 59% of doctors wouldn't recommend a career in medicine to their children. The risk factors can be categorized under personal characteristics, organizational factors, and end-of-life care. Personal characteristics such as being self-critical, having poor coping strategies, sleep deprivation, overall poor work-life balance, fixed idealism, perfectionism, and individual overcommitment are known to contribute to burnout syndrome. And organizational factors such as increased workload, inadequate rewards, poor sense of community, lack of control over environment, poor working relationships, and workplace conflict, of which the last two are potentially modifiable risk factors. Care for dying patients and involvement in decisions to forego life-sustaining treatments are clear stressors. The catastrophic consequences include post-traumatic stress disorder due to frequent exposure to traumatic events, combative patients and family members, and caring about end-of-life issues. The physician may indulge in drug or alcohol abuse. They may even get suicidal thoughts. A strong linear relationship between the burnout scores and medical errors has been noted, and eventually loss of practitioners result in increased healthcare costs, lower productivity, poor morale, reduction in quality of patient care, and higher patient mortality rates. The diagnosis is by the Maslach burnout inventory, in which it is a questionnaire that asks the respondents to score themselves based on a Likert scale, the frequency that they experience certain feelings related to their work. The MBI scores grades the triad of symptoms, that is the emotional exhaustion, depersonalization, and severity of a decreased sense of personal accomplishment. Questions. It's a questionnaire consisting of 22 questions, in which the questions such as: how do you perceive your work? Are you exhausted? How capable are you of shaping your relationship to others? To what degree are you personally fulfilled? Etc. Now, overlapping conditions with BOS include compassion fatigue, in which they have seen a reduction in compassion towards patients and co-workers over a period of time, moral distress, and perceived delivery of inappropriate care. A classical more research is required is often a common conclusion of healthcare research involving wellness committee and other efforts combating burnout. But since this is an issue causing depression, self-isolation, dysfunctional relations, it should be clear that there should be no time to waste. Offer wellness programs at your workplace, provide a more manageable work schedule, increase compensation to avoid financial stress, greater respect from colleagues and the healthcare system, and improved autonomy. Now, implementing various critical care schedules and team models can be adopted. The studies have shown that optimal patient load to intensivist ratio as the 7 to 12 patients per physicians, limiting the number of consecutive ICU days to less than 7, a weekend cross coverage. A day-night shift model, work model has been found to have lesser burnout than on-demand staffing model. Integrating advanced practice providers such as nurse practitioners, physician assistants, residents, and fellow has increased the efficiency of the intensive care. Telemedicine, it has a potential to significantly elevate the workforce, but there must always be a presence of a junior consultant. Another area of concern is women underrepresentation. The women are underrepresented in among the head positions, research works, and presidential positions, and the reasons being higher proportion of family responsibility compared with male counterparts, women having not been in the system long enough. It is called the leaky pipeline theory, in which Mr. Clark Blickenstaff in 2005 coined the term and referred to it as the phenomenon in academia where the proportion of women decreases with each career level. The women are not being considered natural born leaders, and women frequently suffer from imposter syndrome and undervalue their own achievements. The women may not apply for a job if they do not feel if they do not feel that they fulfill 100% of the criteria. Another constantly overlooked are the aging workforce. The activities that cause most amount of stress for them are public speaking, working long hours, litigation fears, and having too much to do at work. Now, how does burnout affect older physicians? Surprisingly, older physicians have less psychological distress, burnout, and suicide ideation than younger and middle-aged colleagues. What accommodations may be required to assist physicians as we age? We should provide age-based decrease in call responsibility or allowing flexibility for part-time work. How do we assess competency and yet maintain integrity? It is recommended to voluntarily do physical examination or cognitive testing after 65 to 70 years of age. Now, to combat burnout syndrome, workplace should amplify voices and highlight leadership roles of underrepresented minorities and create a genuine sense of belonging and respect. Burnout mitigation effort need to start from top down, and the system needs to support the workforce. The workforce should not be crushed under the weight of a broken system. The main goal should be to foster a healthy workforce that engenders a sense of value for unique abilities and experiences, provides equal opportunities to attain promotion and recognition, and to provide a jovial and no barrier work atmosphere. It should retain our talented workforce for a long. Physician-directed interventions involve courses on mindfulness or cognitive behavioral techniques that help enhancing job competence, improve communication skills and coping strategies, and regular exercise and eating healthy. Organization directed interventions involve changes in schedules with reduction in workload intensity, an increase in the level of participation in decision making, changes to the policies and practice with the aim of improving teamwork, and changing the approach to work evaluation and increasing the supervision. In this way, physicians may feel a reduction in job demand and enhancement regarding their job control. Now, lastly, coming to the strategies adopted by our team in AIG, we have an ICU work model involving 2 critical care physicians and 6 physician assistants, and we have incorporated a day-night shift model and weekend cross coverage. Weekly academics and training is given to the nurse and the physician assistant. Our skill enhancement strategies include leadership courses given by management, skill lab, wet lab training programs organized by the hospitals, webinars, conferences, live workshop, and hands-on training, weekly academics and research program. Our OT's work schedule ensures 48 working hours per week, 4 night duties, which are 16-hour shifts, and we get a pre-duty and a post-duty off. We have 2 consultant anesthetists on call per night, ensuring shared responsibility and improved patient care. We have separate OT assistants and anesthesia technician, 1:1 per OT. The women representation in our department is 80%, and women leadership is highly encouraged. We run fellowship programs in regional anesthesia, and we are well equipped to tackle any clinical situations and patient related scenarios, and we have a very good infrastructure. Thank you.
Any comments on this topic? Actually, which is very relevant for the young intensivists.
Very good topic, nicely presented. You covered most of the things, and this is the most required topic for critical care, anesthesiology, emergency doctor. Burnout is very high, but as you rightly said, in your in your hospital, you have a good team. When you have a team in the ICU, you are not the only person. You have pharmacist, physiotherapist, respiratory specialist, and then especially you have to be very good with nurse. If you are not good with nurse, and if you are good, if you are working as a team, then definitely you are relaxed. And the other thing is gender bias that also you touch. And I represent Indian Society of Critical Care Medicine. And this time, after 30 years, we have a woman president. So she took the initiative to give guidelines for gender. Now we see more women in critical care. And if you see all the speakers, so the lot of people, and to avoid gender bias in critical care, we are now we are giving guidelines and about everything about child care leave, and they are entitled to hospitals. That is a problem now based on this fight. So other thing, as you rightly said, tele-ICU. Tele-ICU, like in our ICU, 3 eyes are monitored. One is the doctor inside the ICU. The other one is, and all these patients who could to tele-ICU, one consult. So in between of the patient, you are counseling the patient or you are having a coffee break. The patient is having weak. Who is monitoring the patient? Then the tele-ICU doctor is, they will immediately alert you, and you can, that stress will not be there. When you are having coffee, you will not think about patient. So, and then you have to take in breaks that will, and the noise levels in, if you have too much noise in your ICU, again patients will become delirious, doctor also will. Noise pollution have to that will help. If you look at airlines industry, so you go work pattern of choice of hours they're working in the airline. According to the labor law, you have to work for 48 hours in a week. So that and now the people are taking from the airline industry, implementing here also, because this is, you cannot have like a double duty, even for nurses, for doctors, for anybody, and then you have to strictly follow that. And you should have your hospital have internal conflicts coming. Something happens, where to go on give line. So that internal conflicts committee should be there to help us. Ultimately, you need proper equipment. If you don't have proper equipment, again that will lead to burnout. And you should work. Luckily you are working in a good hospital with all the infrastructure, and you have a nice working pattern. But how many people, how many intensivists blessed with this infrastructure and this kind of facilities? So those things we have to keep in mind, and we have stress at every level, but we are the best people to manage. Whatever you do yoga, you do regular exercise, or you take a break and go for holiday, whatever you take, but you have to take a break, and then you can regenerate and come back and work more efficient. Thank you.
Thank you, sir. Thank you for your time and valuable inputs. With this webinar session, with these 4 webinar sessions, my impression is that it is very important for all the anesthetists to have sound knowledge of perioperative critical care, which really helps in anticipation and early identification of events and managing them. And with these 4 sessions, actually, there were 16 speakers, 16 topics. I would like to thank all the speakers for their time and their excellence in presentation. And with this, on behalf of the Department of Anesthesia, Perioperative Medicine and Critical Care, I'd like to conclude the session and thanks AIG for giving this opportunity. Academic in charge, Mr. Satyanarayana, AV, Mr. Mohan and team, and not but the least, Dr. Nagesh Reddy sir, chairman of this hospital, and Dr. G. V. Rao sir, director of this hospital. Very soon we will be having a workshop in wet lab. Thank you.